Welcome to the debate. Imagine sitting in a clinical consultation room, right? A pregnant patient who is, probably already highly anxious.
Oh, incredibly anxious, yeah.
Yeah. And she's being told that she needs an amniocentesis. So a needle passed through her abdomen to test the genetics of her pregnancy. And the clinician looks at her and says, there is a 1 in 200 chance this procedure will cause a miscarriage.
Right. The classic 1 in 200 figure.
Exactly. For 40 years, that statistic has basically been gospel. I mean, it has terrified countless prospective parents. But the reality is that number is, well, it's a statistical ghost from 1986, from an era when doctors used incredibly thick needles and honestly thrust them in virtually blind.
Which is wild to think about now. I mean, the landscape of prenatal care has fundamentally shifted, right? Yet in so many ways, our systemic rules and really the way we communicate risk are still totally stuck in the past.
Very much so.
So today we are looking at the management and the systemic safety of invasive prenatal diagnostic testing. We're talking about procedures like amniocentesis, chorionic villus sampling, or CVS, and corticentesis. And crucially, we're looking at them specifically through the lens of our modern genomic era.
Right, and this discussion emerges from an April 2026 Master Integrated Synthesis. It's a massive undertaking. It brings together 16 different international guidelines and 42 primary studies.
A huge amount of data.
It really is. And it synthesizes all this data to help us answer this profound, emerging question in fetal medicine. Because over the last decade, non-invasive prenatal testing, or NIPT, has changed absolutely everything.
Yeah, it's a total game changer.
We can now take a simple maternal blood draw, sequence the cell-free DNA, so, the genetic fragments floating in the mother's blood, and get a highly accurate read on the pregnancy without ever going near the womb.
Right.
And NIPT has been so incredibly successful as a primary screen that it has actually reduced the volume of invasive needle procedures by like 50 to 70% worldwide.
Which, I mean, that's an absolute triumph for non-invasive care, right? Less risk, less invasion. But it leaves healthcare systems with a really difficult operational dilemma. Because how do we ensure procedural safety when the operators, the clinicians actually holding the needle, are performing far fewer procedures than they were a decade ago?
Yeah, exactly.
So the few invasive procedures left are often the highly complex, high-risk pregnancies.
Exactly.
Which brings us to the central question we have to answer today. Because procedure volumes have absolutely plummeted, must these invasive procedures be strictly centralized? I mean, should we force a system where only high-volume, specialist hubs are allowed to perform them, using rigid, universally applied protocols?
And that's the core debate.
Right. And I will argue today that systemic centralization, along with strict universal standards, are really the absolutely necessary, statistically reliable ways to mitigate the heightened risks we now face. And I'll be arguing that strict centralization creates unnecessary and honestly harmful barriers to patient access. My position is that rigorous, operator-specific audits combined with context-sensitive clinical guidelines are not just equally safe, but they represent a far more practical, patient-centered model for modern healthcare.
Okay, so let's start by looking at what the synthesis identifies as the volume safety paradox. Like you mentioned, we're doing, 50 to 70% fewer procedures.
Right.
The paradox is that just as these procedures are demanding absolute peak skill because we are only testing the most complex anomalies now, fewer and fewer clinicians are accumulating the sheer reps needed to maintain that skill.
Yeah, the practice just isn't there for everyone.
Exactly. And the evidence here is just hard to ignore. If we look back at the Tabor 2009 data, which drew from this massive national registry, it demonstrated that low-volume departments, which they defined as facilities performing fewer than 500 amniocenteses over a 10-year period, they actually carry an odds ratio of 2.2 for fetal loss compared to high-volume centers.
Right, so essentially a doubling of the baseline risk.
Precisely, a doubling. By simply walking into a clinic that doesn't see a high volume of cases, the patient's risk of losing the pregnancy doubles.
Well,
we just can't rely on scattered, low-volume practice when the stakes are fetal survival. Maintaining safety requires us to centralize, and frankly, it requires rigid, universally applied minimum standards.
I hear you, but
Wait, let me just give you a very mechanical example from the data. Look at twin pregnancies. The Chen 2020 study examined how we perform amniocentesis on twins. Now, historically, some operators used what's called a sliding technique, which is a single needle approach.
right, yeah, that's where you pierce one amniotic sac, you draw the fluid, and then instead of pulling the needle all the way out, you just slide it directly through the dividing membrane into the second twin sac.
Yes,
I mean, it was originally designed to save the mom from getting poked twice.
right. It sounds efficient on paper, but clinically, it's a disaster. You are essentially punching a communication hole between two isolated environments.
Yeah, which is risky.
Very. The Chen data showed that when operators use that single needle sliding technique, fetal loss skyrockets to an unacceptable 7.69%.
Wow.
But when you mandate a double needle technique, meaning, you pull the needle out and make a completely fresh, separate entry for the second twin, the loss rate drops all the way down to 1.53%.
That is a massive difference, obviously.
It is, and that's why systemic safety requires us to mandate these exact techniques from the top down. And honestly, we need to concentrate them in medical hubs, where high patient volume ensures the protocol is practiced flawlessly every single time.
Look, I completely acknowledge the reality of the declining volumes. I mean, NIPT really has hollowed out the routine procedure schedule.
It has.
But relying entirely on geographic centralization creates a massive exclusionary hurdle. I mean, think about the human stakes here for a second. You're asking a pregnant patient who has just received a terrifying scan result suggesting a severe fetal anomaly
Right.
to suddenly coordinate travel, sometimes hours away, to a designated specialist hub. That just totally ignores the operational reality of how people actually access healthcare.
But safety has to come first.
It does, but we have a proven alternative to sheer volume, and that is audit-based accountability. Let's look at the Golkar 2021 model. It's the perfect counterpoint to your centralization argument.
Okay, I know the one.
Yeah, in that study, a single experienced consultant operating in a low-volume unit achieved zero amniocentesis-related fetal losses, 0 losses across 511 procedures.
That's one clinician, though.
But how do you do that without massive daily volume? You do it through strict, meticulous outcome tracking, individual clinical expertise, careful selection of your technique, and auditing every single outcome matter vastly more than some arbitrary volume threshold set by a central committee.
See, I'm not convinced by that line of reasoning because it fundamentally relies on the exception rather than the rule.
How so?
Well, yes, the Golkar model highlights a brilliant, exemplary clinician, but public health policy cannot be designed around the blind hope that every low-volume operator happens to be a statistical outlier in excellence.
I wouldn't call it blind hope if it's audited.
But think about aviation safety. We don't rely on hoping individual pilots naturally maintain their emergency landing skills by, flying a few times a year. Aviation relies on systemic volume, mandatory repetition, and universal thresholds.
Sure, but
A pilot has to log a specific number of hours in the seat. If they don't, they are grounded. A single exemplary operator in a small clinic just doesn't negate the population-wide systemic risk identified by that TABOR data.
okay,
If we allow low-volume centers to keep operating under the vague guise of local audits, we are systematically exposing populations to that 2.2 odds ratio of fetal loss. The healthcare system has to protect the patient from the average operator, not just bank on the exceptional one.
But the aviation analogy actually works perfectly in my favor here, because an airline doesn't just look at a spreadsheet of how many hours a pilot has flown. They put that pilot in a simulator to check how they fly, right?
Well, yes, but
They check how they handle the controls, what specific techniques they use for specific emergencies. Volume is just a proxy for skill. It is not the skill itself. The DGUM 2023 guidelines, that's the German Society for Ultrasound and Medicine, they explicitly state that procedural competence actually plateaus after about 100 procedures.
a plateau doesn't mean
it means doing 500 procedures a year doesn't magically make you 5 times safer than the doctor doing 100, provided you're both using the optimal technique. And technique is the true driver of safety here.
Okay, let's talk about technique then.
Let's do it. Let's look at chorionic villus sampling, or CVS. Specifically, transcervical CVS, where we go through the cervix instead of the abdomen. The Bacher 2017 data analyzed over 29,000 cases of this.
A very robust data set.
Exactly. And they found that when an operator uses a cannula, which is basically a tiny, semi-rigid vacuum straw, the procedure-related excess pregnancy loss is a dangerous 3.12%.
Right.
But when they switch their instrument to a biopsy forceps, these tiny pinchers that cleanly grasp the tissue instead of suctioning and shearing it, the loss plummets to 0.27%.
Oh, the instrument choice is undeniably critical there. I mean, the mechanics of it make perfect sense. Forceps are vastly less traumatic to the delicate cervical tissue.
Exactly. That is a tenfold difference in safety based purely on the physical instrument the doctor is holding. So if a local operator in a lower volume clinic understands the mechanics, uses the correct instrument, the forceps, and prospectively audits their outcomes to prove their safety, why should sheer institutional volume be the sole gatekeeper?
Because
A high-volume center using a dangerous cannula is fundamentally less safe than a low-volume audited center using forceps. We need to standardize the technique. We don't need to centralize the location.
But standardizing the technique requires universal mandates. You can't guarantee every local clinic switches to forceps unless a central authority forces them to.
Guidelines can shape practice without shutting down clinics.
But this brings us to the core of how we actually govern these procedures. You advocate for these context-sensitive, flexible guidelines, but I argue that rigid, universal rules are the only way to ensure patient safety across the board.
I disagree.
Well, let's look at a glaring example from the synthesis regarding maternal viral screening. Think about the physical act of an amniocentesis. You are taking a long needle, pushing it through the mother's abdominal wall, through her blood vessels and into the amniotic cavity, the sterile sanctuary where the fetus lives.
Right.
If the mother has a bloodborne virus, you risk dragging that virus directly into the fetal environment. The SFM India 2021 guideline takes what I consider the only defensible protective stance. It mandates universal HIV, hepatitis B, and hepatitis C testing before all invasive procedures.
A universal mandate that several other major medical societies explicitly advise against, I might add.
They advise against it, sure, but the virological data absolutely supports the caution. Just look at the Chung 2025 scoping review. They looked at hepatitis B specifically in mothers who are HBAG positive with a high viral load. They define a high viral load as 7 log 10 or higher. To put that in plain terms, that means there are millions of copies of the actively replicating virus in a single drop of the mother's blood.
Right.
Chung demonstrated that if you push a needle through that environment, you significantly increase the risk of mother-to-child transmission. But crucially, they also showed that if you administer antiviral therapy to the mother before the procedure, you suppress that viral load and no transmission occurs.
It's a great treat then test paradigm.
It is brilliant, but you can only treat the virus if you know it's there. If you rely on your preferred model, patchy, context-dependent local practices, where universal pre-procedure screening isn't strictly mandated, you will inevitably have operators pushing needles through highly infectious fields.
I wouldn't call it patchy.
It inadvertently infects fetuses. Rigid universal mandates prevent those exact systemic failures.
I come at it from a different way because applying a rigid, sweeping, universal rule completely ignores the infrastructural realities of how medicine is actually practiced on the ground.
How so?
Well, you mentioned other societies disagreeing. The ISUOG guidelines, the International Society of Ultrasound in Obstetrics and Gynecology, and DGUM explicitly recommend against universal pre-procedure screening.
Yes, but
Why? Because context dictates protocol. Let's look at the UK's Royal College of Obstetricians and Gynecologists, the RCOG. They adopt a much more pragmatic, intermediate approach. They advise reviewing available results and individualizing the discussion.
individualizing risk can be dangerous.
Not if you have the data. Imagine a patient in a high-income healthcare setting like a major hospital in London or Berlin. In those systems, routine antenatal screening for HIV, Hep B, and Hep C is already universally conducted in the first trimester.
Okay.
By the time that patient needs a mid-trimester amniocentesis weeks later, her viral status is already sitting securely in her electronic health record. Imposing a rigid universal mandate that says, stop, we must draw blood and rescreen you right now before we do this amniocentesis is a massive waste of clinical resources.
It's redundancy for safety.
It introduces agonizing delays for a patient who is already terrified, and it provides zero additional safety because we already have the data.
But what about settings where that first trimester screening isn't perfectly captured? Or, patients who transfer care late in their pregnancy?
And that is exactly my point about context. In settings where routine antenatal screening is not universal, or the records just aren't reliable, then yes, the SFM India approach of testing immediately prior to the procedure is entirely clinically defensible. It's necessary there.
So you agree the mandate is useful?
In that context. But you cannot blindly apply the SFM India mandate to a London hospital. Universal rules are brittle. They break down when you try to stretch them across diverse, complex healthcare infrastructures.
I don't see it as brittle.
True safety comes from operators having the situational awareness to apply the right protocol for their specific patient population, not from following a global edict that doesn't fit their local reality.
I accept that infrastructural differences exist, but situational awareness is exactly the first thing that degrades when procedure volumes drop. When you aren't doing this every single day, you need the checklist, you need the mandate. You can't just rely on intuition.
It's not intuition, it's reading the chart.
Let's shift, though, to how we actually communicate these risks to the patients themselves, because this is where the synthesis really demands a massive overdue paradigm shift. We talked at the very beginning about that famous 1 in 200 risk figure.
Yes, the 0.5% risk of procedure-related miscarriage. From the famous Tabor 1986 randomized control trial.
Right. And for decades, it was the only RCT in the field, so it became this undisputed benchmark. But the synthesis makes it abundantly clear that this figure is an obsolete artifact.
Completely obsolete.
The medical mechanics of 1986 are unrecognizable today. I mean, back then they used 18-gauge needles, which are essentially the size of a small cocktail straw.
Yeah, it's brutal.
And crucially, they used intermittent ultrasound. The doctor would look at the ultrasound screen to map the womb, put the probe down, and then physically thrust the needle in blind, hoping the fetus hadn't moved.
It's terrifying to even describe.
It is. Today, we use incredibly thin 22-gauge needles, and we perform the procedure under continuous, real-time ultrasound guidance. The operator watches the bright tip of the needle on the monitor every single millimeter of the way.
Right.
Because of these massive technical leaps, the contemporary expert-centered amniocentesis loss rate is actually between 0.06 and 0.22%. That's based on data from Edelman 2006 and Odibo 2008. So I think we both agree the 1 in 200 figure is a ghost that absolutely must be retired.
Completely. I mean, it is medically unethical to sit across from a patient in 2026 and quote a risk figure based on giant needles and blind insertions from the 1980s. It deeply distorts their ability to make an informed decision about their pregnancy.
Where we strongly disagree, however, is on what number should replace it in that consultation room.
Okay.
I argue that we must counsel patients using the contemporary population-level benchmark, the Salomon 2019 meta-analysis, and the Wolf 2016 National Registry place the overall modern risk at 0.30 to 0.50%.
Which is still fairly high.
Yes, it is higher than the 0.06% expert center rate, but it is the honest systemic picture. Not every patient has the luxury or, the geography to access a top-tier high-volume expert center.
Right, but
If a patient is being seen in a standard community hospital, quoting them the expert center rate of 0.13% gives them a totally false sense of security. The population average of 0.30 to 0.50% protects the patient. It gives them a realistic assessment of the system's overall safety, acknowledging the reality that they might be getting a perfectly average operator.
I'm sorry, but I just don't buy that. Let me tell you why.
Go ahead.
Quoting a population average of 0.50% to a patient when the specific doctor sitting right in front of them actually has a personal loss rate of 0.1% is a fundamental violation of informed consent.
How is it a violation?
Because it actively misleads the patient about the reality of the room they are sitting in. Population averages mask the reality of individual operator skill. When you use a pooled average, You are mathematically lumping the brilliant, meticulous clinicians together with the dangerous, outdated ones.
It averages out the risk.
No, you dilute the risk of the bad operators, giving them statistical cover, while simultaneously punishing the excellent operators by forcing them to quote an artificially high risk to their patients.
But if a patient doesn't know which type of operator they are sitting with, the population average is the safest mathematical bet to prepare them for the worst-case scenario.
But they should know. That is the entire foundation of the audit-based accountability model I'm arguing for. Patients must be empowered with operator-specific and center-specific data.
If the data is even reliable.
If we adopt the RCOG audit standards across the board, every single operator is required to track their 14-day procedure-related pregnancy loss, their laboratory culture failure rates, and how often they have to insert the needle multiple times.
Right.
When a patient sits down for counseling, the clinician shouldn't just spout a global average. They should hand the patient a sheet that says, here is the global data, but more importantly, here is my personal data.
But
if we just quote Solomon 2019 pooled average, we are hiding the very audit data that the Golkar model proves is essential. We owe patients the precise truth of the clinician's hands they are trusting, not a statistical average of 1,000 doctors they will never meet.
okay, the fatal flaw with operator-specific data in the NIPT era is statistical noise.
Noise?
Yes, think about the math. If an operator is only performing 20 procedures a year because NIPT has decimated their clinical volume,
Right.
and they have one unfortunate, completely unpreventable miscarriage, perhaps due to an underlying issue with the pregnancy itself, their personal loss rate for that year mathematically looks like 5%.
Well, statistically, yes, but
That makes a perfectly safe doctor look like a highly dangerous outlier. It's sheer statistical bad luck in a tiny sample size, but it would terrify a patient. The population average smooths out that noise and provides a reliable, grounded baseline.
I still think context is key.
And this brings us right back to the volume safety paradox we started with. You simply cannot rely on local audits when the sample sizes at these local clinics are shrinking to the point of statistical irrelevance. Population-level safety in an era of dropping procedure volumes demands centralization.
I disagree.
We must concentrate the cases into hubs so the statistics actually mean something again. And we must apply uniform, universal standardization to prevent the entire system's safety profile from deteriorating.
And I maintain that relying on arbitrary volume metrics and rigid universal rules ultimately harms the patient by compromising access. You are forcing them to travel far from their homes, their families, and their support networks for a procedure that can absolutely be done safely in their own community.
If properly standardized,
Yes. An audit isn't just a blind look at a single year's percentage. It's a cumulative, qualitative review of a doctor's entire practice over time. Locally audited, context-aware practice focusing heavily on the right physical mechanics, like mandating forceps and transcervical CVS and actively tracking those real-world outcomes, provides the optimal balance. It ensures safety without sacrificing the patient's fundamental accessibility to care.
Well, despite our deep structural disagreement on how these procedures should be governed and, whether they should be centralized, it is highly encouraging that the synthesis has brought us to several crucial points of convergence regarding the technical evolution of the field.
Absolutely. We are completely aligned that the era of citing the 1 in 200 miscarriage risk must end today.
Yes.
It is a statistical ghost from 1986 that no longer reflects the reality of modern, continuous ultrasound guidance and ultra-thin needles.
Definitely. And we also agree on the physical mechanics of tissue sampling. We must universally retire the cannulant in favor of biopsy forceps for transcervical CVS, given that undeniable tenfold safety differential in the data.
Agreed. And similarly, the mechanical evidence is now indisputable regarding twins. The double needle technique, making 2 clean, separate entries, must be the absolute standard of care for twin amniocentesis, completely replacing that high-risk single-needle sliding approach.
Yeah. As genomic testing, particularly things like exome sequencing, and the ever-expanding capabilities of NIPT continues to fundamentally reshape the landscape of fetal medicine, the balance we've debated today will remain critical.
It really will.
Deciding between strict systemic oversight and flexible, audited clinical independence will require constant, vigilant evaluation by the medical community.
The diagnostic tools are getting incredibly sharp, but the ground is constantly shifting beneath the clinicians using them. It will ultimately be up to healthcare systems, practitioners, and the listeners to decide which operational model best ensures that prenatal diagnostics remain exceptionally safe without becoming a geographic luxury.
We started today by talking about the terrifying reality of a patient sitting in a consultation room weighing the risks to her pregnancy. When the volume of procedures drops and the margin for error narrows, how do we best protect that patient?
Right.
Do we force every procedure into a centralized, highly regulated hub, or do we trust local clinicians to adapt, provided we meticulously audit their performance? That is the tension at the heart of modern fetal medicine. Thank you for joining us.